get started, let's talk about post-care. I know people don't usually say anything about post-care, but any kind of GI study or anything with barium, what do they tell the patient to do? Drink lots of water. Okay, so post-care for any type of barium study, even gastrographin, they tell them to drink a lot of water. So the first one I'm going to talk about is an esophagram. Some places call it a barium swallow, and some places call barium swallows with the speech people. So it all depends upon your facility. Okay, so indications. There's 4 basic indications. Number 1 is dysphagia. In case you forgot, it's D-Y-S-P-H-A-G. Not an S, G-I-A. Why did I emphasize the G instead of an S? One's what? Speaking? Okay. Dysphagia is difficulty speaking. Dysphagia with a G is difficulty swallowing. Okay, number 2, possible foreign body. Okay, number 3, any abnormality. It's a general term. Basically of the pharynx and the esophagus, if we're doing an esophagram. Okay, last thing, esophageal varices. We talked about those last week. What are esophageal varices? Okay, the large veins in the esophagus, usually from what? Backup of what? Liver. Close. So it's a backup of blood from the liver. So the liver's, something's wrong with the liver, usually cirrhosis. Remember what it looks like? Worms. Good, black wavy worms or beads of rosary. Okay, patient prep. So the first thing you need to know, basically there's no GI prep, meaning they don't tell them to withhold food or anything. That's what that means. So no GI tract prep. They have to remove all radiopaque objects from the waist up. So that would include earrings. You usually get the patient history with all of these. You get a patient history. Always make sure you explain the exam to the patient. And if a doctor's involved, what should you do? Like if the doctor comes in and does part of it. Yeah. Always introduce the doctor to the patient because you've been talking to the patient before the doctor walks in usually. Okay, barium setup. And I wrote all this one out. Okay, so it all depends upon what they're doing and what they're looking for. Sometimes you use thick and or thin, so one or the other, or sometimes both. You can also use the CO2 crystals, the sparklies they call them. When we do the CO2 and the barium, we call that what kind of study? Good. We call it, when you use two different types of imaging media, I guess you can say, you call it a double contrast. Okay, make a little note like this. I see this on some registry stuff. Sometimes you use barium pills. You seen it? Okay, when do they want to use those? Yeah, if they're having issues with dysphagia, with swallowing, they'll give them a barium pill. It's a big, those of you who hasn't seen the barium pills? You haven't? They're just big, they look like, I don't know, big, what were those things called that you used to eat? Anyway, it was candy.
It's almost Smartie.
Huh?
Like a Smartie.
No, they were these big things. I can't remember what they're called. But these,
Tums.
No, they're bigger than Tums. They're about this big, and they're just like little flat pills. They call them barium pills. Okay, procedure. Oh, I didn't write that down. Sorry. All right, I skipped that. The esophagram procedure. Sorry.
How many do you have?
I have 3.
Oh, okay.
So we're going to talk about whether they do the patient erect versus supine first. Which one is mostly used?
Erect.
Erect, okay. Preferably erect, the patient is standing erect. Barium's usually in the left hand. Okay, if they did it supine, it causes the esophagus to fill up a little bit larger. Okay, if they Trendelenburg the patient, it causes the barium to stay in the esophagus the longest. If they Trendelenburg the patient, that's what causes the barium to stay there the longest. It's just common sense. Erect, it moves really fast. Supine, it doesn't move as fast. And Trendelenburg, it moves really slow. Okay, exercises to demonstrate pathology or problems. First one is the Valsalva maneuver. For those of you that have been in fluoro, I'm sure you've seen it. What's the Valsalva maneuver? There's a couple ways to do it. They tell the patient to bear down like they're having a bowel movement.
What do you mean bear down? Like strain?
Yeah. Like, see them do that? Okay. Okay. It demonstrates well the esophageal varices. They're just putting pressure. Okay, so it increases the venous pressure when they bear down like that. Okay, there's another one they call the modified Valsalva maneuver. According to your book, they probably just do this they tell them to pinch their nose and blow. Hold their nose and blow out, try and blow out. Demonstrates the same thing. Okay, if they put the patient Trendelenburg doing a Valsalva maneuver, it demonstrates it even better. Because that increases venous pressure the most. The Valsalva maneuver itself, it also demonstrates esophageal varices or esophageal reflux and hiatal hernias. I've seen it on registry review stuff. What position best demonstrates hiatal hernias? That would be Trendelenburg.
What is Trendelenburg? Did you say
What is
that?
Trendelenburg, you guys?
That's the tilting
Yeah,
around the
the-
head?
Yeah, the head's down and the feet are up. A lot of patients freak out. The older folks, they don't like that. They freak out. Okay, there's something called the water test. So it's with the, just like it says, it's with the use of water. Sometimes they just make it very thin barium, really, really thin barium. This one also demonstrates the same thing, esophageal reflux and hiatal hernias. Those of you that have been there, that's the one where they tell them drink, fast. All right. Okay, routine projections for an esophagram. The best projection is the RAO or LPO, same thing. Okay, the reason why it removes the esophagus from the spine and it removes the esophagus from the spine and it places it between the heart and the spine. So it just settles right in there. Sometimes they just do AP or PA, and sometimes they do a right or left lateral. But mainly this is the one I want you guys to know about, the REO or LPO. Okay, we're moving on. We're leaving the esophagus, we're moving on to the GI series, gastrointestinal series. So this one is to demonstrate the distal esophagus. The stomach. The duodenum. And sometimes they continue on to the small bowel. They can use single contrast, but most of the time it's double contrast.
It's on your patient prep.
That's coming up. Okay, patient prep. The goal is to have a totally empty stomach for a GI series. If they're doing a UGI, they need to have a totally empty stomach. So they're NPO after midnight. What does NPO stand for? Good, nothing by mouth. If they're having a small bowel series after the GI, it's NPO after the evening meal.
You said they have a small bowel?
If they're having a GI study and a small bowel, it's NPO after the evening meal. Okay, they specifically say do not chew gum. Or smoke, that's the other one. Don't chew gum or smoke after midnight. Why not? Yeah, it stimulates the gastric juices. post-fluoro routine projections. That just means the doctor usually comes in, he looks around a little bit under fluoro, and then some of you guys will do routine projections after the doctor leaves. Okay, the first one is, I didn't write them down. First one is a recumbent RAO. This demonstrates the pylorus. The duodenal bulb. And the C loop on profile. So it just kind of spreads those structures out. You think there's going to be barium in them when they're RAO or air? Barium. Okay. So those structures should have barium in them when you're RAO. Because they're laying down like this, so
Right,
barium.
so it's going toward, okay.
Okay, LPO. LPO demonstrates the same thing. It's the mirror opposite, correct, of an RAO? Except there's going to be air in those structures. Okay, right lateral is usually done. This demonstrates the anterior and posterior aspects of the stomach. Also demonstrates the pyloric canal. The C loop and what they call the right retrogastric space. Okay, AP projection. Where's the barium gonna be if they're AP? There's the fundus of your stomach sits like that. Okay, the barium's gonna be in the fundus. If they're AP, the barium will be in the fundus.
You're still supine?
AP or supine.
Oh,
If they're PA or prone, it's the opposite. The fundus has air, the fundus will have air in it.
If it's prone, is it?
If it's PA or prone. And those two are just general survey. AP and PA, just a general survey. Okay, there's something called a PA axial. That's with the beam angled PA axial. Whenever you see axial, it means that the beam or something's angled. PA axial, the beam is angled about 35 to 40 degrees. Cephalad.
You say 35 to 40?
35 to 40 degrees cephalad. This will open up the high horizontal stomach.
The what?
High horizontal stomach. What type of body habitus would that be? stomach that's really high and horizontal. Hyperstenic, that would be the hyperstenic folks. Okay, and then they do what they call bulb shots, B-U-L-B, bulb shots, meaning duodenal bulb shots. Central ray for the stenic patient, the average size patient is L1, L2. Level of L1, L2. I see that on registry stuff. I don't know why they ask that kind of stuff, but anyway. Okay, REO. Okay. Central rays L1, L2. These are bulb shots. If it's an REO, there's going to be barium in the bulb.
Sorry, the central ray for REO is
For the bulb shots, L1, L2.
It'll be barium.
REO barium is in the bulb. So LPO, air in the bulb. So they do them REO and LPO. Okay, small bowel studies. Okay, I wrote these down. Sometimes it's a GI with the small bowel. Sometimes it's just a small bowel. Some places call it SBF. Sometimes they add a T on. Small bowel follow through.
Can you repeat that one more? Oh, never mind, it's numbered.
And the last type of small bowel series I'm going to talk about is enteroclysis. Okay, small bowel patient prep. I just talked about it earlier. It's NPO after the evening meal. No gum chewing or no cigarettes. Guess nowadays you could say vaping as well, huh? Okay, contrast media. If the patient already, if they're doing a follow-through after the GI series, so usually how much barium do they drink with the GI series? Usually it's a cup, like 8 ounces. So usually they drink a cup for a regular GI series. If they're having a small bowel after a GI series, they drink 1 more cup. If they had a GI already, they drink 1 more cup of barium. They're just having a small bowel series, they drink 2 cups of barium.
so SBF would be 1 cup and the GI with small bowel would be 2 cups.
Well, they both will equal 2 cups. So
Oh,
if they already had a
okay.
GI, they're just gonna drink 1 more cup.
Mhm.
If they're just having a small bowel study, they're gonna drink 2 whole cups of barium. Okay. All right, timing. Small bowel series timing. It's supposed to begin the minute they drink the first sip of barium. So whether they've had a GI or not. Okay, then usually, not every place, but usually for the first hour, how often do they take an image? Good, every 15 minutes for the first hour. Okay, the second hour, every 30, good. And then after that, it's every hour until what?
So this large intestine.
Good, until it reaches the large intestine. Basically, when it gets to the cecum. Okay, so basically, when they have a GI first, you're gonna take an image right away, a KUB, right away. And that would be your first film, because that's about 15 minutes, okay, for the GI and your second cup of barium. Okay, central ray for the GI. They're KUBs, right? You're doing KUBs. But you center a little bit higher at first, because the barium's up high, or the ever way down there. So you center a little bit higher, then you just see where the barium is. And you just get lower and lower. Okay, there's ways that you can increase or try to increase the motility or make it go faster. If the patient can't walk, usually they tell them to walk around. If they can walk around, they say to walk around. What if they can't walk around? What do you have them do? Good. Make sure that they're laying on their right side. You can also add a little bit of saline or, I need to tell you this, gastrographin to the cup of barium.
Why is it so bad?
Because you're really not supposed to add. Saline's not bad, but gastrographin you really shouldn't. IV does it all the time. Okay, cold or warm water? Cold. Should use cold water. Some places put little chips of ice in it. Ice chips. Okay, the last thing, it's kind of cruel because they're starving. Talk about their favorite food. What's your favorite food? You guys do that? Yeah, kind of cruel.
Actually, I enjoy it.
I do too. I like to talk about food. Okay, enteroclysis. I'm going to talk about enteroclysis just a little bit. So the enteroclysis, this is a study of the small bowel. And with the enteroclysis, you directly introduce the barium into the small bowel. How do we do that?
Like a tube?
A big tube. It's enteroclysis tube, sometimes a really big feeding tube. Okay, so they just inject it into this big feeding tube and study the small bowel that way. Okay, all these clinical notations, if you want to look them over, that's totally up to you that I gave you. If not, don't worry about it, because I went over everything that would be on your test. Any questions? Okay.
So there's no clinical notations on the test? Besides like what you told us, there's no clinical notations?
Unless you just want to look them over. Otherwise, they won't be on specifically on your test.
When you come back RIO, put your weight on the right side, and then lift their, your right side, lift your leg up, the left leg. I think well last year. Radiologist was like, it's alright out. Yes, I know.
Sometimes radiologists don't have the patience.
No. Just kind of
Do you have specific ones at St. John that do the floral studies? Or
no,
who's that
all
all?
of them do.
Yeah. All right, well, let's do lab in about 15-20 minutes. I'm just gonna go over it. I wonder if we should just do it together. I'm gonna go over large bowel. That way y'all on Thursday. It's up to you guys. It won't take very long. I'm gonna go over large bowel, images. I can do it all together. You wanna start it now?
Yeah, because I have to be at work.
Yeah, it won't take long. Yeah, I'll hang them up and we'll start now. Is that okay with everybody?
Yep.
Okay. I don't know why I separated.